Welcome back to another exciting episode of It's Your Health. We have an overwhelming fountain of information this year, this episode to review. We'll be back in just a minute. Just remember, anything we talk about, anything, even about the weather, you should talk to your healthcare provider first before you implement any of those changes. All right, we're ready to start the first segment here of It's Your Health. Where do we start? What's the first thing we do?
It starts with an H, headlines.
Headlines, that's right. Let's get back to some headlines. All right. Half the usual drug dose for heart failure may work better in women.
Sure, this is not a sexist approach, correct? It is basically looking at ACEs and ARBs. Those are common medications we use for heart failure. Reduced ejection fraction, mind you. That they found when they give regular doses to more of the female population that they had more side effects and adverse outcomes from the typical dose of these medications, and that it was found that maybe reducing the dose by 25 or even 50% had better outcomes when initiating these medications.
Let's stay on that heart failure kind of theme, and let's now talk about Farxiga now has been shown to provide benefit in heart failure patients. Now, Farxiga is a diabetic medication.
Yeah, it's we're seeing this trend. We've talked about it, of course, on It's Your Health, as we talk about always.
This is the only place you hear this kind of riveting information.
Groundbreaking evidence. And so these SGLT2 inhibitors, basically medications that allow you to pee out a lot of the blood sugar, almost act as a water pill. And we're starting to see a trend where these improve cardiovascular outcomes in patients with heart failure. More heart failure with reduced ejection fraction. We discussed on prior episodes that diastolic heart failure, these drugs don't typically provide as great a benefit as with the reduced ejection fraction.
I think it's exciting because this whole class is showing a lot of promise. I mean, they now have indications for, renal protection, which we used to think to stay away from these medications for people with kidney problems. Now people who have had a heart attack or have had a stent or some type of intervention, we're using these medications. And by the way, these are in non-diabetic patients. I believe the heart failure indication is in a non-diabetic population. So that's very interesting. Alrighty, it's getting back into we're slowly eking back into spring here. Let's talk about bouncing back.
Sure, so as we recover from the holidays, trying to lose some of that holiday weight, we may be looking at different ways to exercise, and some people like to do more so at home or do alternative strategies. And I came across this article in a women's magazine that my wife was reading, not myself. I know you would rag on me for that. But it shows a trampoline and using trampoline workouts. And I thought, one of the common phrases by an orthopedist is that we commonly see people with injuries due to the trampoline. We ourselves were not allowed to use a trampoline when we grew up because our father was concerned about having a fracture of our leg because of that.
Yeah, we never had anything like that, but we had all kinds of other fun things we did. But certainly, I think the idea is getting moving, and if this is a fun way to move, so be it. But you have to be very careful. After 10 years of inactivity, to sit and hop onto a trampoline, that's what's going to put an orthopedic surgeon's kids through school. So you need to take that advice carefully, and so find other ways to sit and exercise. Maybe not so much jumping on a trampoline. Alrighty, let's move on now and start talking about something that we've run into. Actually, this is a part of weekly life. And let's talk about gallstones. Let's talk about gallbladder disease.
Yeah, very common. We see a lot of it. And gallstones are formed from cholesterol or pigmented. And the gallbladder basically has a storage of these bile acids. And so that helps absorb fats and emulsifies and does all that fun stuff to help us stay healthy. But sometimes the gallbladder can become diseased. And we notice that common scenario, right upper quadrant pain. People get worse pain after they eat. Stabbing sometimes doubles them over. Sometimes they can get a little diarrhea, change in stool color. It can become dangerous to a point where you can get an infection in there. The stone could migrate down and affect the pancreas or the bowel. And so it can be a big problem. And we typically will evaluate it. It's a diagnosis generally made on clinical exam and then kind of supplemented with imaging such as an abdominal ultrasound.
Yeah, it's gallbladders are kind of funny things. They often will have the symptoms we talk about, but because of the way our nerves work in our abdomen, they often can be very marauding. People who have chest pain, that can be gallbladder disease. People can have shoulder pain. They can have back pain. And the typical feature between all of those is when did they get that pain and associated with food eating. So if they have a salad, does it hurt? Not so much. If they have pizza or wings, an hour later, are they doubled over? And it's certainly worth looking into. Gallstones and gallbladder disease, to me, I've always said it's a ticking time bomb. It's important to get that addressed right away. The problem is we don't know when that timer is going to go off, and you can wait a year or two with gallstones and maybe get off okay. Getting your gallbladder taken out is same-day surgery. It takes 45 minutes. You hang out in the hospital in the morning, you're out in the afternoon. Yeah. If you wait for your gallbladder to blow itself apart, you're going to be in hospital a long time, and you're going to be a sick kid. That can really cause a lot of problems once those stones start flying all over the place or you start getting an infection. That's something we really got to watch. Yeah. So let's talk a little bit, that we just recently got an email about overall, how our health is here in Luzerne County. And, they ranked out all the counties in Pennsylvania. And where did Luzerne County end up on that ranking?
I'd like to hope number one, but it's not. It's 60 out of 67. So actually kind of eye-opening,
right.
To be honest. I thought maybe we'd rank a little bit better. Certainly the area has its challenges with health and access to health, although that's always improving through Lehigh Valley, of course. But I feel as though it's our duty to kind of bring this up and to mention kind of to reevaluate and make sure that we are kind of being stewards of good health and making sure that we're taking care of ourselves, because these numbers are shocking.
Yeah, I think when we look at poor health in a community, some of that has to do with the medical community trying to get out the word, and I feel that we spend a lot of time trying to talk about lifestyle changes, but a lot of these health things are self-induced. It's bad diet, bad exercise, smoking, alcohol consumption. That kind of that triad of problems is going to equal bad health. And I mean, look at Luzerne County. We have some of the highest amount of bars per person. There's going to be a penalty to pay for that, and so, we need to work hard, or, we can't get much lower, and but we certainly have a lot of room to improve, and it'll be exciting to be a part of that improvement, to see us over the next few years try to improve the health of the community in general.
Oh, certainly, and I think that kind of ties in with some of the other health topics we talked about. There are medications that certainly help with the weight loss, improving overall health, reducing cardiovascular risk, which is kind of why we're all here.
Right. Well, that was one of the fastest segments. I didn't think we would fit it. We could have probably spent the whole show on this, but let's take a commercial break and we'll regroup, and we'll be back for the second segment of It's Your Health. Welcome back to the second segment of It's Your Health. The first one flew by. The second one, we're going to try to slow it down, try to get a little bit more information in, see what we can do. Let's start back up with some headlines.
Excellent.
Inhaled corticosteroids reduces lung cancer risk in COPD.
Yeah, inhaled steroids for COPD, always a moving target a little bit. I know the guidelines have changed in terms of how we manage COPD patients, which we'll talk about in a little bit. But it was interesting to come across this. I believe it's from reduced inflammation, which allows for lowering the risk of lung cancer. Now, association versus causation, that's always something that needs to be kind of twiddled out. But I think overall this is kind of reassuring to patients who are on long-standing inhaled corticosteroids.
Yeah, I agree that, I started, working at a time where inhaled corticosteroids for COPD were extremely important, and you really weren't doing your patients a service by not putting them on them. They had to be on them. Mm-hmm. And now, with these recent changes, now they're like, well, they're kind of poo-pooing them and they're saying we shouldn't use them. And the thing is they work. People do feel better on them. It's hard to argue that. There are some occasional side effects we run into, but overall I think this is kind of exciting, and it makes sense. We reduce inflammation, we should reduce cell turnover. Mm-hmm. Less cell turnover means less chance of cancer. It'll be neat to see how that article kind of teases itself out. Moving forward, benzodiazepine use may increase the risk of pneumonia.
Yeah, we've kind of talked about risks of benzodiazepine use, not only by itself, but with opioids and other medications. They specifically talked about Ativan, or lorazepam, as well as Sonata, which I don't typically run across too much, and then Restoril. Those last two are usually for sleep aids. But they found that people with the use of those actually have more of a risk of developing pneumonia, especially in people with impaired lung function.
Right. I think that's a pretty interesting. Some of it actually makes sense. I'd be curious because two of those are sleep aids, and so they're using these at night. You know, are you not protecting your airway quite as well because you're over sedated? You know, what's actually happening?
Yeah.
You know, certainly cause for concern because you know, these medications sometimes historically are being used in middle-aged patients, and then they're getting to be older, and you know, maybe it's not a great idea for mom to be going to sleep with a sleeping pill at night. You know, there's certainly some risk for that. Aside from all the fall risk and other bad things that can happen. So certainly gives pause. Lastly, third-hand smoke, a new concept rising from old residue. This is a great article. I learned a lot about this.
Very interesting. It was something new to me that I came across. We always hear of first smoke, secondhand smoke. Third-hand smoke is typically the residue of smoke. So we kind of run across this in the office. You'll have someone come in. You can already tell off the bat, are you still smoking? Yeah, I kind of know you are because I can smell it on your clothes and what have you. It's in their cars, it's on their clothes, it's on their hair and stuff, and it's on the surfaces in their furniture in their house. And the thought is that we then ingest these kind of chemicals that are byproducts of the smoke. So it's not necessarily inhaling it, but almost ingesting it. And it's a risk with younger kids. They're walking around, they're cruising around, they got their hands in their mouth. They're, you know, filthy little animals sometimes. And so they're the ones who are at risk for getting these adverse effects from this third-hand smoke. And it's thought that you try to reduce the environment entirely. So you don't even smoke in a car, that you have children in a car. You don't smoke in a house, that you have children in a house. And these are kind of ways to kind of go about that.
Yeah, I found that pretty interesting. You know, I always understand the perils of first and second-hand smoke, but the concept of third-hand smoke, or the layering effect of that, you know, that I think reigns true because there are a lot of people that smoke in rooms that, you know, of course they're not going to put their kids in the room hopefully while they're smoking, but they'll say afterward, oh, okay, it's okay, I'm done smoking now. But that stuff is all over the place. It just doesn't disappear into thin air. It does leave a residue. So I found that to be an interesting article. Moving forward, let's get, I hate to keep harping on the smokers, but let's talk about the association of e-cigarette use and cardiovascular disease.
Sure, they found that e-cigarette use, especially when you're combining it with traditional combustion smoking, your cardiovascular risk increases for having an adverse event. And it's kind of interesting, we see on a next slide that the associated with lung injuries as well with vaping has increased over the past year, actually over the past 3 months, I believe. So these, we're seeing more and more trends of vaping, and then more and more people vaping and smoking at the same time. And the thought, I've talked to patients, they say, well, I'm vaping and it's reduced my overall cigarette consumption. You know, I think it's overall healthier, when in fact it actually increases your risk of some of these poor outcomes. Absolutely.
And you know, if vaping's part of a concrete plan, a 3-month plan to get off cigarettes completely, okay. You know, I don't think you're going to kill yourself in 3 months. However, when it's just a substitute, that's what gets you in trouble. I find the biggest problem with vaping is because it's so much more socially acceptable. People will vape in their cars. They won't smoke in their car. People will vape in their house. They won't smoke in their house. People vape in my office. I've walked into a room and have patients vaping. I'm like, you can't do that here. Well, I'm not smoking. No. The thing is what that then creates is more access to nicotine. And so you end up, I think, increasing your addiction to nicotine because you're having it so much more. You may smoke half a pack a day, but you'll hit that vape pen, you know, how many times a day? Sometimes 100. And so it really kind of increases that addiction. And then when you finally, like, I've had enough of this vape, you go back to smoke, you're now smoking 2 packs a day. And so that's my biggest problem with vaping. You know, well, it's one of my biggest problems. There's a lot of problems I have with vaping.
It's an issue.
So moving on, let's try to wrap up this second segment. It's going fast. I'm getting the signal. Let's talk about positive and negative predictors for an acute MI. Like when we think about a heart attack, chest pain, shortness of breath, what are some of the most important things for you to hear that you're like, oh God, this is serious? Or as soon as you hear them say this, you're like, it's probably not a big deal.
Sure. So typical chest pain, it's central in the chest, left-sided maybe, pressure, heaviness associated with exertion, and goes away with rest or nitroglycerin. Those are kind of the typical chest pain cardinal symptoms. There are also atypical and non-cardiac chest pain, which kind of has 2 of them, then 1 or 0 of them. And this article found that when it's associated with pressure, heaviness, and it radiates to both arms, not just the left arm that we always hear about, but when it radiates to both arms, you have a real high clinical suspicion that this chest pain is actually cardiac. Someone coming in saying, oh, I got sharp chest pain, I'm resting, it kind of just goes away on its own. It doesn't really radiate anywhere. Certainly we want to evaluate for cardiac causes, but it may be less likely of a cardiac cause.
Right. My favorite one is when someone is up at the ER and I'm going to check them out for chest pain and they say, oh, I have chest pain. I say, well, point to me exactly where it is, and they show me. And I'm like, does it hurt when I push there? Like, oh yeah, that's the pain. You can't push on heart pain. If it's a pain that they have there, whether you push or not, and it's there, it needs to be evaluated a little bit more. And so we have more stuff to talk about in the second segment. We're going to have to punt that to the third segment.
Wow.
We'll be right back after these brief commercial messages on It's Your Health. Welcome back to the third segment of It's Your Health. This is the last segment. I would like to see maybe a 4th segment. I think that would really fit the bill. But here we are. We just can't do it. Let's get back to some headlines, get these through so we can get talking. All righty. Red meat risks.
Sure. We've kind of followed this for a while, that increased consumption of red meat certainly has adverse effects. They found that out of 80,000 plus people that consumed red meat kind of regularly, had an increased risk of death 8 years within that period. And so we commonly see people who eat a lot of red meat, risk of colon cancer, heart disease. Certainly if you're barbecuing, grilling, a lot of charred food, that can always increase the risk of gastric cancers. We typically don't think of that. So usually less is more when it comes to red meat.
Yeah, I was actually, there was a study a few years ago that kind of highlighted this, and I was kind of caught off guard. And so I do like my red meat, but I personally tried to limit it to like once a week, and if it stretches out longer than that, that's fine. But there's a lot of healthier ways to get protein that is not red meat. I get it, it tastes delicious, but it's not necessarily that good for you. Save it as a treat. Recent studies showed the effects of caffeine and how it correlates with migraines.
Yeah, we see this sometimes with patients who, when you do a good social history and ask about coffee use, I hear some people say, oh yeah, I drink, pot of coffee in the morning and pot of coffee in the afternoon. That's a lot of coffee. And they're finding that excessive caffeine use, greater than 2 cups per day, can be associated with migraines and headaches. So certainly when you're dealing with some of these chronic migraine sufferers, doing a detailed history on caffeine consumption is an easy low-hanging fruit, so to speak, to kind of modify their lifestyle to maybe reduce those headaches.
It's real interesting. It makes sense. Caffeine's a vasoconstrictor. Vasoconstriction is what initially causes the trigger or the aura of a migraine. It's also interesting that we use caffeine to treat them.
Sure.
So that's once you kind of have the blown out headache. I said, but it makes sense that we should cut that back. That amount of caffeine use just isn't good. But you're right, too many. And then the hidden caffeine. I don't drink that much coffee. But you see they have a Red Bull, a Bang, or all these crazy Monster energy drinks. Well, how many of those do you have a day? Well, I have 4 of those a day. I'm like, oh my gosh, that's like 15 cups of coffee. The energy drink consumption in today's day is really astounding. Yeah. To try to make up for lack of sleep and excess work, it's just crazy. That's a big no. Alrighty. Left behind.
Left behind. So this is about, they looked at a study. So we talked about a little bit of Luzerne County from 2000 to 2010 and how our health is kind of poor. And they looked at this study from 1999 to 2010, and they found within the family unit, and we talk about the family unit sometimes, is that there's poor behaviors being seen with less eating at the dinner table, less having breakfast together, more screen time, and this is causing poor health in overall population throughout the U.S. And this isn't something that is a shock and awe type of thing. If you're seeing more screen time, not eating healthy, and the family unit is kind of disruptive, we see kind of poor health decisions being made, and also people's health being poor in general.
Yeah, I look back to our childhood often when we talk about this stuff, and that is actually one thing we did a pretty good job of, is we did all, as busy as everybody was, we usually sat for dinner. We had dinner as a family. It never was kind of partitioned out, this person eats, that person eats, and we kind of did sit down as that unit, which was, I think, a good thing. And in my own home, we try to do that as well, more and more, and I think it does make a difference.
I remember the spaghetti pot, where our dad would make it in that big glass, Pyrex glass spaghetti pot, and we'd all just eat out of it. I think he was just lazy and didn't want to do dishes.
Yeah, that's true. But we usually had to do the dishes, so I'm not so sure. Alrighty, so let's talk about, this is a condition that, we see with some frequency, but it's really not talked about it, but hidradenitis suppurativa.
Wow, say that 3 times fast.
I'll just say the hidradenitis suppurativa.
I think you nailed it. It's basically very common. We see it a lot. We see it in individuals in their axilla, their armpits. We'll see it in the groin, also their gluteal region. It can be painful. It can almost represent like a sebaceous cyst, but it's a overactive inflammatory condition within that sweat gland. And it ranges from severities, mild, moderate, severe, and in that terms ranges from how do we treat it. Easiest way is good hygiene, appropriate hygiene, keeping clean, keeping things dry, no excessive moisture. And then also, as it gets more severe, then we start to turn to topical treatments, antibiotics usually, oral antibiotics. And then usually the last one is surgery and then biologic injectables. I don't know, you've seen this case a couple of times?
I've seen kind of I've seen the mild, where it's someone who says, yeah, I just have kind of an infected hair follicle, or I have a blocked pore, and you'll look at it and you can see 1 or 2 other ones there as well, and you're like, you may have something else going on here. Let's talk about this. That's the mild case. I've had the severe cases where they've been through multiple resections, multiple surgeries, abscesses constantly forming, tunneling, and it's just an absolute train wreck. IV antibiotics, typically the bugs that get involved in this are highly resistant to antibiotics because they've been treated so many times over the years. And so you have to use some pretty big stuff. And then they'll sometimes end up seeing a dermatologist and get put on a biologic. And that kind of owes to some of the autoimmune component to this. And that it's more than just, some bad follicles, and those are the more severe cases. Once it gets really under control properly, it really can be life-changing, but it can be very detrimental to leave this untreated and let it go. It can get really out of hand.
Oh, certainly.
Moving on. Let's look at a peculiar case of purpura.
This sounds
Tell me what purpura is.
Purpura is usually, we see it as a rash, of course, that's very general, but it has a specific finding, which we'll show a picture in a second, and it's usually purple. It's not palpable or blanching, so you press on it and it's still there. And we see it in a variety of conditions, and you can see it in vasculitis. That's one of the more common internal medicine kind of questions for purpura. You can see it in hepatitis C, some more rare conditions as well with cryoglobulinemia. And then interestingly, in this article that I ran across, I thought of you specifically, vitamin C deficiency, because you're a big fan of scurvy.
Yeah, I think it's a pretty interesting article, because scurvy is something, at least in the industrialized world, we just don't see. And scurvy is a vitamin C deficiency. And this was something that was typically people in colonies where they didn't have access to citrus type things. Sailors years ago, scurvy was a very common problem. But, I'll be honest, I don't know the last time I thought, I bet this person could have scurvy, nor even do the proper testing for it. It's really kind of low on the radar, but it is something to think about for, some peculiar rashes in different conditions.
Oh, certainly. And I think for this case, they had an individual who had more obsessive thoughts and obsessive control over what they were eating, and they were very regimented in what they were eating, which we're commonly seeing today in people doing some of these more extreme dieting techniques and maybe are limiting what they're eating and not getting a whole balance of food. And interestingly enough, when they did check kind of their blood counts, there was anemia, which can be seen with vitamin C. And then also they saw when they checked their folate and vitamin C levels that the vitamin C level was low.
Cool stuff. That's the third segment.
Wow.
There is no fourth segment. I am sorry. You'll just have to watch another show. And there are other shows. I'd like to thank you all for joining us for this episode of It's Your Health. We really had a lot of fun covering a lot of topics. If you have any questions or any things you want us to cover, call the station. The number's here on the bottom, and they can get a hold of us, and so we can talk about whatever you want. We'll see you on the next It's Your Health.